special visit premiums. This is now something more common, not just to emergency medicine. This is also applicable to family medicine, hospitalist, and many other services, SVP. This is essentially when you're asked to come into the hospital for a special reason. So for example, if you're the backup doctor for the emergency department in your hospital, and because of excessive volumes or multiple codes happening at the same time, you were asked to come into the emergency room as a backup doctor. This is to account for the extra travels that you're putting in, and you're coming in just for a specific purpose. So if you were called in, the SVP that you get paid, again, depends on the day and the time. So weekdays, like Monday to Friday, 7 to 5 p.m., which is different from the H codes, which are 8 to 5 p.m., 7 to 5 p.m., versus evening, 5 to midnight, or holidays, or nights. Nights are midnight to 7 a.m. Depending on when you were called in, you can apply these K codes. These are essentially a premium for coming in for a special purpose. Essentially, there is a travel premium. Like if you had to come in all the way from home into the hospital, if you came in hypothetically on a weekday, you can bill, for example, K960. So that's the accounting of the travel. And then they have a first patient scene and a second additional patient scene extra codes, essentially extra bonuses for the number of patients that you're seeing. So for example, on a weekend, the emerge was really busy, you were called in as a backup doctor, you can bill, for example, a travel code, K963. The first patient you saw, you're not billing the regular H codes because these are special visits. You actually bill something called A codes. You bill a first patient code plus whatever your regular ER billings are. And then for second patient onwards, you bill a special code, K999. And every time of the day has a maximum. So you can bill this for maximum of 20 patients. On a weeknight, you can bill for a maximum of 10 patients. On a weekday, also maximum of 10 patients. So if you end up getting called in because the department is busy and you see 10 patients on a weekday, you can bill these special premium codes. After the first 10 patients, you're going back to a regular emerge billing schedule. On a weekend, up to 20 patients, you can bill a special code. Overnight actually has no limit. If you get called into the hospital after midnight, there's definitely a very huge premium or bonus essentially for coming in at nighttime. Now, these K codes are special codes, essentially, so they kind of conflict with your H codes, which is your regular emerge codes. So that is why when you bill essentially travel codes, you're billing something called A00123. These are family medicine codes. A007 is like an average family, like an intermediate family medicine clinic visit is A007. That'll be like the equivalent of a multi-system code in emerge in the H code world. A003, if you had to examine somebody literally head to toe for some major reason, that is the equivalent of a comprehensive H code. So you'll be using travel codes plus A codes for special visit premiums. And again, it really applies if you were particularly specifically called into the emergency for a specific reason. The most common scenario is you are the backup doctor and you were called to come in because the ER is really busy. That's the most common scenario. The second scenario is typically if there's, God forbid, multiple codes and let's say there's only one doctor in the ER, they need backup and help. That is typically another scenario where you get called in. Now, hospitalists have it, family medicine has it, internists have special visit premiums. And you just need to know for emerge, like, you just need to build a travel code that is specifically for emerge.
A quick question about the A codes. Some doctors, family doctors who work in a FO might have their billings negated when other doctors bill A001, 007, or 003.
Yeah.
So do you ever recommend emerge docs bill A888 on the weekends instead?
My understanding with A888 is don't the appointments have to be booked?
Oh, it has to be booked. Okay, because sometimes some walk-in clinics will bill A888 as well, especially if it's weekends. So the main question is basically like, how will it negate faux family doctors?
Yeah.
Unless they have the +1, right? Like, I guess if they have the +1 in EM, then maybe it won't. But if it's a family doctor without the +1, then it won't negate. Yeah. If it's a 5-year trained emerge doc, it won't negate.
Yeah. So with the 5-year emerge docs, it will typically not negate because they are a different specialty by coding. The family doctor, even if you have an emerge designation, it will negate any codes that will normally negate a faux doctor will still negate.
Mm-hmm.
So that's kind of like, billing 10, the next 201, I would say.
Yeah.
Because if you know how to play around with the codes, but this also requires familiarity with the family medicine and faux world, which I find is so challenging of its own. I know you've done videos on faux billings, but if you know which codes negate a family doctor, you can try to minimize using it or avoid using it. So, for example, if you had conversation about death and dying with a patient you saw, on a special visit premium, instead of using A007, use K023. Like, it's a palliative code that does not negate the family doctors. Family doctors can bill K023 also, but that is an out-of-basket code.
Gotcha. So if you're a 5-year emerge doc, would you still bill something like this, A007?
You would. And so if your designation is a Royal College designation, when you bill any family medicine kind of clinic codes, it does not negate family doctors. But if you're a family doctor with additional training in emergency medicine, or even without the training, you're working in an emergency department, there are certain primary care codes that you could use because you're a family doctor. And if a patient is enrolled in a family health organization or faux health model, it could negate some of the income from the family doctor. So that is a whole different level of billing to understand which codes could potentially negate a family doctor and which codes don't. Yeah. So we've talked about H codes, E codes, special travel premiums, and now going on to K codes. So K codes are typically associated with some sort of counseling in general. That's what in primary care for clinic settings, or maybe even some of the specialist colleagues that do counseling may end up using K codes. K codes require documenting time, and it's minimum 20 units that you have to document. So this is what I said at the very beginning. For some of these codes, time matters. So you need to document a start and stop time. So here are some examples. Commonly used. K005 is if you end up doing mental health counseling, you can bill that particular code and you document the time. K013 is a general counseling or education you gave. Somebody came in, let's say, in depression, and again, they're not suicidal. You decide they don't need to stay in the hospital, but you spend half an hour with them really understanding the state of their mental health. You can use a counseling code, and sometimes a counseling code might end up being more beneficial financially than an H code. So for example, on a weekday, a patient comes in feeling depressed, and you did a full history mental status exam and you diagnosed them as depression. And H102 might pay $40 or $42. Versus if you actually spend 30 minutes with the patient in total, you could totally bill a K013, which pays about $67. So this is where, depending on the time of the day, K codes may be more advantageous than billing just your bread and butter H code. It's very common in Emerge that you're counseling relatives in the context of very sick patients. So that is where K015 comes into place. And again, depending on, you need to document the time. And then there's some unique codes that, again, if you don't think about it, you typically don't end up billing it. For example, somebody comes in with a needle stick injury. There's actually a whole code for that. Sexual health, if somebody has a diagnosis or symptoms of an STI, there's a specific code for that. So these also, again, pay $67 compared to $30, $40, $50, depending on the time of the day you may end up seeing the patient. So it's a good idea to kind of start having a framework of K codes. So you get to eventually see, in certain scenarios, these might be potentially more lucrative than billing just your straightforward H codes. If for any reason you're billing in H, your regular Emerge codes, and K codes, typically one will get rejected unless you do something called manual submission. Now, for example, if they did come in with a medical issue like, doc, I have a rash here, what is it? And then, by the way, I'm also depressed, and you do some counseling there, you end up doing two very different things with very different outcomes for the patient. You will need to manually submit it because the OHIP, some of these codes on the back end are automatically designed, if you build these two, they're going to reject each other. So you may have to do something called manual submission should you have dealt with two very different issues that qualify for two very different codes. So they normally would negate each other, or only one will get built, not that they would entirely negate each other. So I would pick one or the other. Very common code used in the emergency room is K623. Mental health is on the rise in society, and there's no shortage of mental health issues coming through the emergency department. If for any reason you think the patient is unsafe to themselves or unsafe to others, or severe psychosis or actively suicidal, things like that, you're admitting that patient under a Form 1. And typically for Form 1, it's case 623. It's a standalone code if you're deciding, okay, this patient is going to be admitted to psychiatry involuntarily. You will just bill this 1K code. You're not billing an H code with it. It will automatically get rejected. And it pays quite a generous amount at almost $115 actually. So, I would be billing this code for any patient you admit under Form 1 over an H code. And as you can see from some of the other examples here, you spoke to Children's Aid Society and someone is brought in by the police and you need collected blood for them. That anything, think about anytime you do any sort of long, I think about if I spend a lot of time talking about something, does this now qualify as counseling of some sort that could qualify for a K code? So that's the first column. The second column in the context of eMERGE that is quite relevant is phone consults. Anytime you pick up the phone to call anyone on behalf of the patient, think to yourself, is there a code for this? Depending on which emergency department you work in and how close you're to a tertiary center, there may be needs to call specialists, family members, reportable diseases, public health, or Criticall for any critically ill patients. So keep in back of the mind, anytime you pick up the phone, ask yourself, is there a code for this? So I will start with consults between hospitals or between doctors. Now, not all hospitals have every specialty. There are times where you may need to make a phone call to another emergency department, for example, or a specialist that is not available in the hospital to get advice about a patient. So if it's not a critical scenario and it's just regular advice you need from a subspecialist, for example, and you spend 10 minutes talking about the case, and typically it ends up adding to 10 minutes because you have to call them and then you end up having to introduce your patient, the diagnosis, and why you ended up calling that specialist and getting their response. You can build a specific code called K735. So this is, again, you are calling another doctor to get consult over the phone. So if this is a case where you call them and they're physically in the hospital and come to see the patient, this does not count. This is entirely where you're relying on that phone advice for that patient. On the other hand, if you're calling about a critical illness, life or limb threatening illness, Ontario has a special 1-800 number that you can call from anywhere in the province. And essentially this particular office, their goal is to connect you with a specialist that you need in a life-threatening situation as soon as possible. So when you're calling for a critically ill patient, there's a separate code for it, K736. And typically, again, these calls take definitely more than 10 minutes because you have to call, they have to collect the patient information, they have to collect information on what the diagnosis is and what kind of specialist you need to be connected to. And this particular office does find a specialist for you, potentially, typically from a tertiary center to call you back that may give you advice over the phone on what to do about the patient, or may ask you to transfer the patient to their care. But if you make a phone call to Criticall, that is absolutely billable. Other reasons why you may pick up the phone on behalf of the patient is you are reporting to the Ministry of Health or your local public health unit about any reportable disease. For example, if somebody had STIs that are reportable, you will need to call or report it to public health while you're on a shift. You can bill for that. If somebody got a dog bite and you need rabies vaccine for that patient and you're calling public health, you can bill for that. So things like that. Anytime you pick up the phone, ask yourself, is there a code I could be using for this? Now, calling back patients for diagnosis or test results that come back a few days later. Now, you have left your shift, patient is long gone from your ER. Every ER department has a different policy around how you do callbacks. Sometimes some ER departments will have an assigned doctor, like every morning that'll receive all the test results from the last few days. If there's a critical result that needs to be informed to the patient, somebody might be assigned to do it. Or in some hospitals, each doctor is responsible for calling back any of the patients they saw themselves. So every hospital has different policy around it. Please find out the policy in your emergency department on how they do callbacks and how callbacks are billed. Some hospitals where they have the alternate funding model may have a plan where it's the physician that does callbacks get paid by the hour or for every call they make. If you have to bill it as a fee-for-service, service, then in that case, post-pandemic, there's new OHIP codes for phoning patient A102, and you get for calling the patient about a diagnosis or a treatment. If there's any reason you need to call them using a video service, there's a separate code for that as well for callbacks. The other thing I needed to remind you here is when you're calling for critical reasons, anything but critical, you need to get the OHIP number of another physician you speak to, if it's a phone call between two doctors. This is more in the wheelhouse of primary care doctors, family doctors, and very, very big part of the job. But occasionally in the emergency department, you may be asked to complete forms. The most common and important form I would argue that you might be doing as fully as part of your job is involuntary admission into the psychiatric ward. That's called a Form 1. And that form is CCFP-EM FRCPC, pays quite well. If you are admitting a patient involuntarily to the psych department, know that depending on the time of the day and the reason they came in, there might be additional codes that qualify. So for example, you admit the patient for Form 1, but they tried to overdose. They were actively suicidal and they tried to overdose. So here you're managing a mental health issue for which you're admitting them, but also you're managing the overdose. There's a critical physical condition here that you're dealing with. In that case, a K code and a G code can be billed together. And if you're billing this on a weekend or after midnight, there's these extra premium codes, H112, 113, that you can activate. Other forms that you may end up doing is for any reason you're asking patients to get antibiotics at home or requesting some sort of home care to go in and complete a form for that. You can do that. Occasionally, if you are reporting a patient's license, there are certain health conditions that may occur that may involve physicians reporting license. There is a specific code, K035, reporting to the Ministry of Transport. Again, for calling public health, there's a code. And typically, if you ended up having to fill any long-term care related form, which is not too common, that you can bill a code for that as well. Anytime you have, again, any communication over the phone with allied health, like the local CCAC, home care coordinators, social workers, document the name of the person you talk to, again, as proof of your, proof for billing the K code. Okay. All right, the G codes. Now, these are some of the most premium codes in an emergency department. So the two not to miss and not to forget codes in the emergency world is your regular H codes, that's your average patient, and G codes are your life or limb threatening codes. Unlike H codes, which have like very fixed price regardless of kind of how much time you spend with the patient, G codes are entirely time-based. I call it big G and little g in the sense that OHIP has two different set of G codes. I'm going to talk about little g first. In this case, you got G395, G391. These are almost like mini recesses. This is not where the patient is kind of like fully in a code blue situation, but might be heading there and they're critically ill. The first 15 minutes will give you a certain pay. And depending on how many 15-minute blocks you spend with the patient, there's a different code for that. You can write G391 times 3 units, for example, if you spend an extra 45 minutes with them after the first 15 minutes. So for example, if you spend 1 full hour with the patient, that might be, for example, in shock of some kind, but they're not like imminently dying, you might choose to bill a little G code, I call it. First 15 minutes, G395, and the next 45 minutes, you can bill G391 times 3 units because it's 3 times 15-minute blocks that you measure the G codes. It doesn't have to be consecutive times. For example, a patient was in septic shock, you come in, you throw all your initial investigations and antibiotics, fluids, all that up front, and then you may come back for a reassessment for another half an hour. So it doesn't have to be consecutive time at this point. So that's little g. Little g, typically I think about situations where the patient is really unwell, but they're not imminently dying or at risk of dying or imminently life or limb. Versus the big G is your absolute critical care. Think about big bad things that happen in the ER. So heart attacks, strokes, traumas, any code blue, code pink, anyone where somebody's imminently dying, absolutely you bill your big G or critical care codes. Now this one, again, pays significantly more, time-based. Every 15 minutes is your billing. First 15 minutes is G521. So it pays about $115 now, I think. Then the second 15 minutes, G523. And then the third 15 minutes, so this is minute 30 to minute 45. So that next 15-minute block, you actually bill G522. you can actually, the one error here is you can bill up to 6 G522s. So calculate the total amount of time that you spend with the patient, and you bill how many units every 15 minutes. Now, if sometimes you might be doing things concurrently, like you might be running a code blue, but you might also be stepping aside and having a chat with a relative of a patient to understand, for example, their code status. Are they DNR? Are they full code? So even though there's a separate code for counseling relatives of terminally ill patients, that K code and G codes don't mix. You would include the time you spend talking in a critical situation like this, where you're asking the relatives or finding out the code status as part of your critical care for the patient. Okay. And this is, again, which G do you choose, big G or little g, as we call them in the ER? Some of the questions I always say you ask yourself is the patient imminently dying? Are they at risk of dying in the next few hours if they're not treated? So an example would be if they're in severe septic shock. Is it a life or limb case? What are their vitals like? So sometimes they could be potentially looking less sick than they actually are. And then you look at the numbers and you're like, holy, all the vitals are off. They need to be immediately moved to resus area and we need to immediately start treatment. So that could be another clue into how severely ill they are. Think about if you can add any premiums to it. So essentially you can add H112, 113 here, or in the context of mental health, if you're planning to admit them to psychiatry afterwards involuntarily, you can throw in case 623, which is your form 1. But in the case where a patient has acute mental health and acute medical issues, you're treating the medical issue first, medically clearing them before they end up going to the psychiatry ward. You cannot put any procedures in these life-threatening situations. So the very high pay here, relatively speaking to the H codes, is to account for the fact that you might be doing procedures in parallel. So in a code blue situation, for example, you could be putting in a central line, you could be intubating the patient, you could be giving anesthesia. So you could be doing procedures kind of as you go along throughout a code. And these codes and its pay is meant to reflect the complexity, and therefore you would not be billing any additional procedures for this G codes. Combining codes. It's almost like a puzzle to figure out the coding system of the eMERGE. And I've alluded to this example a few times now, but very rare situations can you start combining codes where it doesn't get rejected. So the classic example of combining a K and a G code, so G codes are a life-threatening case, typically the forms that you complete or the counseling you do, is in the context of mental health and a medical issue. So particularly, for example, if a patient comes in, a usual scenario is overdosing as part of a suicide attempt that was not successful. They were found, brought to the hospital. You're managing the overdose, but at the same time, because they were acutely suicidal, after that medical issue is managed, they are going to be admitted to the psych ward. This is where you might be putting the patient on a form 1. So in this scenario, you might be managing in a very acute medical condition. For example, if they were unconscious from whatever overdose they are, you might be dealing with that. And then you're admitting them to psychiatry. You'll be putting both G codes and a K code. And you can add your premiums in this situation. If they're not imminently life-threatening, if the patient has maybe an average medical issue that is not life-threatening and they're suicidal, you wouldn't be putting an H code. It would get rejected. H's in case get rejected. G's in case, the answer is it depends. If there's a scenario that justifies billing 2 very different codes that normally would negate, you only get paid for one, you can do something called manual submission to OHIP. Normally, whatever billing software you or your billing agents use, once billings get submitted, OHIP has kind of automatic acceptance or rejection methods. Sometimes complex codes, complex procedures may need to be manually submitted. And at the OHIP office where you're affiliated with, there's people actually that read your claim, your manual claim, and decide, should I approve this code or not? So that's called manual submission, which you might do through fax or email to the OHIP office. This is a great area where, again, you can make really good income if you end up doing anesthesia for your patient. So not all the time an anesthesiologist is available if you need to put a patient to sleep. If your hospital has anesthesia and they're available and they can come down to you, great, get that help. But in scenarios where you cannot get that help, you may have to potentially call in a colleague to come in and help you. So this is a code. You might be billing the regular ER codes, and a colleague might end up billing the anesthesia billing codes. So a procedure, you're going to reset, put a bone back into place, and you need somebody to give sedation to the patient. The doctor doing the sedation for whatever procedure you are doing will take that code, add a C at the end instead of A. Most billing codes end with an A. Add a C at the end and document the time that they did for that spend on that procedure. How long were you with the patient, for example, from the start of anesthesia care, like giving the propofol till the patient woke up. That whole time you can get paid for it. So the way you would pay is, again, I put XXX here because that will be whatever procedure was happening for which you were called to give anesthesia for. And typically most procedures give like 6 units of pay. And I think each unit is around like $17 or something like that. And you get multiply that by 6. Plus in 15-minute units, there's time units. But again, if you're using a billing software app, you can enter the start time of your procedure or when you started doing anesthesia and when your anesthesia care entered, and it can calculate the time units for you, but they're typically in 15-minute allocations in terms of how many time units you spend with the patient. The 2 extras that I just mentioned here is occasionally if you're doing a rare kind of procedure for which there isn't a procedure code, but a full-on procedure, full-on anesthesia required, there is a generic code _E023 that is available in this scenario. And in very rare scenarios, if you have to do an acute upper airway management and where you have to do surgical intervention for the airway or anything like that as part of like anesthesia care, and anesthesia was not coming down to do it and an emerge doc did it, there's a specific code E013 which pays really well for that. Now, typically anesthesia is done in the context of some sort of procedure. You can't bill procedure and anesthesia. You have to bill one or the other. So if there's 2 emerge docs involved, one can bill procedure code, one can bill anesthesia code. Now, if you're the only emerge doc in the department, you have to pick one or the other. You can't bill both. And then there's some premiums associated with it, like if the patient is more complex, if they have a higher ASA number, there's a special extra E code you can add based on the time of the day, E400, E401, there's extra premiums. If their BMI is calculated and is a certain number, there's extra premium for that. Age premiums don't apply anymore. That's apparently automatically built in now in the back end of the OHIP's billing system. Procedure billings, again, there's tons of procedures, so I'm not going to go into it, but all to say, any procedures you do, think, is there a code for this? Typically, any kind of common procedures are fractures and reductions, dislocations, lacerations, tons of that we do in our emergency world, INDs like incisions and debridements that you've done, removing foreign bodies, lumbar puncture, chest tubes, cardioelectroversions, any procedure you can think of, there's more likely not a code for it. So this is on top of your regular age codes that you can add these procedure codes. Anytime you bill a procedure code, there's a premium, E412, 413. We talked about it earlier on. Keep in mind complexity. Again, every procedure may have some sort of modifiers or code for different. If you did a complex laceration and you spend 30 minutes doing it, don't bill a simple laceration code, 𝗧17C. There's a complex code that you can find if you spend a significant amount of time. Or certain areas of the body, like if you had to stitch a lac on the eye, that's very delicate, could take a long time. So certain body parts may potentially qualify, like face, earlobes, vaginal laceration, muscle repair. If you're doing deep layers of repairs, can qualify for more pay. Believe it or not, with laceration, you need to document how big the laceration was, or approximately, because the size determines how much you get paid. So that's procedure codes in a nutshell. The one addition, it's not quite a procedure, but something I will say here is G313P. So if you're interpreting ECGs, which you would be doing quite often in an emergency room, there is a code. If you actually write your impression on top of the ECG and sign off on it, there is a code you can build, G313P. It pays about $4 per ECG. But find out if your ER group or hospital has a policy around it. This is, I say, a bit controversial because some hospitals may have a cardiology team that actually reviews, interprets ECG and signs off on it. So you may be told you cannot bill for it. So again, some may have a doctor at the end of the day reviewing all the ECGs of the day who ends up billing for it. But find out if your particular ER group has a policy around it. And nerve blocks, typically you're not thinking about it when you're doing procedures, but if you had to do a whole nerve block for any reason, see if there's any code associated with it. And I put 2 examples here, infraorbital and cranial nerve blocks. Okay. Yes, there was an arrow pop up there. Just under fractures, if you ended up just like splinting it versus you actually needed to like reduce a joint or a bone, there may potentially be different codes for that. Whether you have to do it under anesthesia versus without anesthesia, there might be different codes with that. Okay. And okay, I'm going to kind of skip, other than saying that again, there might be complex codes like stitching an eyelid, or a finger, multiple fingers got lacerated and you had to stitch multiple fingers back together, anything that took a lot of time. Think in your head, if it's complex and you spend a lot of time on it, ask yourself, could there possibly be a billing code for it? And this is just an example, just showing, eyes, nose, any kind of foreign body from any orifice of the body, complex repairs. There's probably a code for it in the ER. All right, we're coming to the tail end. So that's like, complex billing about ER with OHIP. Then you got patients coming in outside of OHIP. So if somebody is a refugee or they belong in the military, they actually have a separate insurance in this country, typically administered through a company called Blue Cross. So they typically have a piece of paper that actually has a note that says, this patient is a refugee or military member, and this is their insurance number. And that goes through a very different billing website, or your billing agent should be able to submit that for you. Then if they're out of province, except for Quebec, typically your regular billing programs, you can just bill your regular codes, and the provinces have a reciprocal relationship where if you cross provinces and someone from outside Ontario comes here, OHIP kind of gets the money from that province directly through whatever billing software you use. You're not having to bill through any special mechanism. The only exception is Quebec. Quebec does not have the same reciprocal relationship with OHIP. So you can't bill through OHIP and Quebec government pay you. Typically, you end up having to bill if you have to bill the Quebec Ministry of Health directly, it will take a long time, usually in the span of months, to get paid. So a suggestion might be to bill the patient up front if you can, and give them the receipts, and they can go and submit it to their Ministry of Health or their equivalent of OHIP to get reimbursed. Any workplace injury, you're still billing your regular emerge codes, but you're billing it to WSIB, Workplace Safety and Insurance Board, and not to OHIP. Most billing apps, softwares, or billing agents know how to do it, and you will have to mark that patient sticker chart as a WSIB payment. It should not be going through regular OHIP payment. A little trick here, if you have to fill out a Form 8, which is where a worker was injured, comes to the emerge, you're reporting that injury to WSIB. If you fax the form in, there's a $65 physician fee that you get. But if you fill it out online, you get $80. So it's a $20 difference per form. And over the course of your time, months, years in the ER, it can add up to an interesting amount of money down the road. If anybody else is outside of any of these insurances, there's something called OMA rates. You can take whatever your regular OHIP billing code would have been, and every year OMA recommends a multiplier. So regular OHIP code multiplied by, in this case, 2024, 2.7, and that bigger amount is what you can bill a patient who does not have these regular insurances. And you need to find out what your ER group or hospital have, if they have any policies around how to get paid for uninsured patients. Sometimes they may get billed at the door itself. As soon as they register, they may collect some money up front and then pay it to the physician that saw the patient. Sometimes they expect physicians to collect money from the patients themselves, and this is where you need to come up with a method, whether it be cash, debit, credit, e-transfers, to collect money directly from the patient, which can be challenging in the middle of an ER shift when you're already running around to think about one more thing to do. Or you can use, your smartphone and certain apps that can help do billings kind of on the spot for uninsured patient. If you're billing patients directly outside of OHIP, you have to present them with a bill and invoice them essentially what codes you used and what are you billing them for the exact amount, and give them a receipt or an invoice. So you need to figure out for yourself how you're going to generate that invoice or receipt in your ER. So whether it be online, email, or a physical receipt book that some doctors keep with them. Last but not least, that brings us to the very end of the talk, but I always say it's very complex, tons of codes. I always ask, if you're new to emerge or emerge billing, ask yourself or your team, who are the expert billers in the group and who bill ethically, and see if you can sit down with them. I highly recommend, if you're early in your career in emerge in Ontario, to sit down with an experienced biller and go through the patient sticker list, or however you organize your patient list for a given shift. Go through with someone experienced colleague to see, have you billed appropriately for all your patients? Have you billed all the bonuses, premiums, documented all the times, billed uninsured patients, or out of OHIP, everything was done correctly? Because if you start to forget codes, which you can easily when there's a ton of codes, over time, these add up to lost income for fair work done. So highly recommend sitting down with colleagues or anyone who's willing to help you, the billing agents, to make sure you're billing appropriately right from the get-go. So with that, I will stop there. And that was, again, billing 101. There's a lot more depth to all of these codes, but as you can tell, it's already a complex system to bill in an Ontario ER. And I hope that was helpful for you.
Great. Thank you, Dr. Joseph, for all of the information that you provided. It was a lot of information to take in all at once. And if you are a family doctor or you're a specialist and you want to collaborate with me on any videos related to billing or practice management, just reach out. If you have any questions, just leave us a comment. Thank you, everyone.